Francesca. So my objective today, yes, is to convince you that maybe it could be possible, maybe to get a sustained remission in these complicated autoimmune diseases just by depleting completely one cell subtype, which are B cells. And it's a new topic of our group now in IDMIT, and we are very excited about this subject. So here are my conflicts. You do know, and I don't have to recall that autoimmune diseases are frequent, 10% of the population, more common in women than in men, and are in augmentation during the past 10 years, and they will continue to augment. Until the beginning of this century, we thought that T cells were the main cells involved in autoimmunity, because T cells is the cell recognizing the peptide, and in numbers of animal models, autoimmune disease were transferred by T cells, and autoantibodies were considered just as a hallmark of the disease, but without any pathogenic role. Actually, B cells play a key role in autoimmune diseases. Of course, B cells can differentiate into plasma cells and secrete autoantibodies. B cells can secrete cytokines, and B cells is also a very, very efficient presenter of peptide to T cells. And these three elements make that B cells really play a key role. And just an example about an antibody, there was this experiment now 25 years ago by a French group working in Strasbourg at that time. Now Christophe Benoit and Diane Matisse work in Boston. And they used to work in diabetes, and they crossed numbers of mice with not mice, which is mice prone to develop diabetes. And in these mice, one time they developed spontaneous polyarthritis. And this polyarthritis was transferable to other mice just by antibodies, just by IgG. And actually, they could look that anti-GPI antibody were the antibodies that could transfer the disease. Of course, at that time, we looked at our freezers and at the serum of our patients. But in human, it's completely different. And one time again, human is not mice, and in humans, anti-GPI antibody are not responsible for rheumatoid arthritis. But it was an example that an autoimmune disease could be transferred only by autoantibodies. So I said that B cells is a very good presenter, and I think it's very important. And this experiment made now 25 years ago by Schlumschick group is very, very interesting, because they looked at a mouse model, which is MRL-LPR mice. It is a model of lupus, Sjögren, and rheumatoid arthritis. It is a mixed model, and it is transferred by T cells. There is an infiltration of T cells, and you can transfer the disease by T cells. So if you modify the B cells without any possibility of membrane immunoglobulin and any secretion of antibody, you don't get any T cell infiltrate. The B cell are important. And it's not the autoantibody secretion, because if you modify the B cells with membrane immunoglobulin present at the surface of the B cells, but no possibility of secretion of antibodies, you get a T cell infiltrate. So it is probably by the presentation of antigens of peptide by TCR, by the recognition of peptides by TCR, peptide presented by B cells on the MHC. And you know that the B cells has all the machinery for the co-activations of the T cells, CD8086, CD40, binding to CD40 ligand, and BAFF receptor. I will speak of BAFF receptor later. So B cells are important. And what kind of B cells are important in autoimmune diseases? You do know this schema of differentiation of B cells. So we differentiate the B cells going through a T-dependent differentiation in the germinal center. Very important selection in the germinal center. So you have the naive B cells that go into the germinal center and might be selected in memory B cells. And in most of the cases, there is a switch to IgG, IgA, IgE. But there is another way of differentiation independent of the germinal center, which lead to which occur in the marginal zone. And so you can get some memory marginal zone B cells. And these B cells are mostly IgM CD27 positive, but they can also switch, and you can have some plasma cells derived from these B cells, IgG or IgA. So you are going to see that the objective of B cell therapy in autoimmune diseases is to delete the memory B cells, whatever they are, T dependent or T independent, and to reset the B cell repertoire to more naive B cells. So here are the markers of the ontogeny of B cells, and you can see that these markers are differentially expressed. CD19 is expressed along the differentiation from probe to plasmablast, and even early plasma cell may express CD19. 20 is less expressed, and you have also some marker more expressed on plasma cells like BCMA, and Taki will speak again on these markers. So the first B-cell targeted therapy was designed at the end of the 20th century. It is anti-CD20 monoclonal antibody Rituximab. It was licensed in the US and in Europe in 1997 for the treatment of B-cell lymphoma. Indeed, this drug, what does this drug do? This drug is able to kill the B cells. You can see that CD20 is expressed as a membrane of the B cells, and Rituximab is a chimeric antibody, and is going to lead to apoptosis of the B cells by different mechanisms, which are CDC, ADCC, and direct apoptosis. So Rituximab may kill the B cell. It is still a treatment which continues to be used in some malignant hematologic disease, in some type of lymphoma especially. And 5 years later, in the beginning of the 2000, British rheumatologist Joe Edwards had the idea to use Rituximab in rheumatoid arthritis. And the idea of Joe was really to kill the B cells secreting autoantibodies and secreting mainly rheumatoid factor, which is an important autoantibody in RA. And so he treated patients with very refractory RA, not responsive to methotrexate, and you can see with 3 different ways of using Rituximab, he got some very nice response compared to placebo. So as expected, the B cells completely disappeared in the blood, as you can see, up to 6 months, and you had a decrease of the autoantibodies. Rheumatoid factor had a nice decrease, as you can see, and more than the classical IgG, which are also decreased, but not as much as the rheumatoid factor with 3 Rituximab regimen. As you can see, is a placebo. There's a bolus of steroid at the beginning, so it explains why you have this slight decrease in rheumatoid factor at the beginning, coming back to the baseline. So Rituximab is licensed in 3 autoimmune diseases. As you can see, rheumatoid arthritis, pemphigus, which is a cutaneous disease, and vasculitis, the systemic vasculitis, which is ANCA-associated vasculitis. But it is used in clinical practice in numbers of other autoimmune diseases, because even though there is no clear demonstration with an RCT, a randomized control trial, we continue to use this drug very, very commonly in these patients with autoimmune disease in the clinics. And we have designed some predictive markers of prolonged response with Rituximab. You can see here that it is these patients had a very prolonged response after Rituximab. So you have the B cell depletion, as I have said, and progressively the B cell reappear. But in these patients with prolonged remission, what happened is that the B cells which reappear are mostly naive B cells, 27 negative IgD positive B cells, as you can see here. And the memory B cell, here, the switch memory B cells or non-switch memory B cells, you can see here that there is a repopulation which is much less important than before Rituximab. So it is the perfect situation in which you might have a long-term remission. But this situation occurs in a very small minority of patients after rituximab. Why? Probably because rituximab is a very good B-cell depleter in the blood, but actually does not deplete the B-cells in the tissue. It is just the example of salivary gland in patients with Sjögren's disease. As you can see that after rituximab, you have exactly the same percentage of B-cell clones. The number of clones, the size of the clone did not change compared to before rituximab. It is the same in the other tissue, in the synovium for rheumatoid arthritis, in the kidney for lupus, etc. It is the same. And finally, why? So to try to understand why there is no tissue depletion, we can have to discuss about a system which is very important for activating autoimmune B cells, which is the BAFF-APRIL system. BAFF is a key cytokine for activating autoimmune B cells, for activating B cells in general, but mainly autoimmune B cells. So you see that this cytokine, which is secreted by monocytes, macrophages, neutrophils, which is secreted, is going to bind in the B cells. The most important receptor is BAFF receptor. And BAFF receptor, when it is bound by BAFF, can lead to activation of the B cells. And for example, ABC, H B cells, which play a key role in autoimmune diseases, express a lot of BAFF receptor. So we have a drug, which is belimumab, which can inhibit BAFF. BAFF is involved in autoimmune disease, and you do know that in our group, we have been working in BAFF now for 25 years, and we have really firstly demonstrated its involvement in Sjögren, but it is also involved in lupus. It is increased BAFF or BLyS. It is the same in the serum of the patients, correlated with the level of autoantibodies, as you can see here. It is expressed by the T cells infiltrating the gland, and that's completely abnormal. Normally, T cells do not express BAFF. And what is very interesting is that when you stimulate epithelial cells with type 1 interferon, you can see that BAFF can be secreted by epithelial cells in the context of Sjögren. So really, BAFF is a key cytokine for activating B cells in Sjögren. What is interesting is when you treat the patients with belimumab, lupus patients here, you have, at the beginning of the treatment, a decrease of memory B cells in the blood, as you can see here. And a long time, these B cells return to the baseline level. So there is this decrease, and this decrease maybe could be due to the fact that BAFF play a role for attracting the B cells in the nodes, in the tissue, in conjunction with CXL13, as you can see in this paper. So because rituximab works very well for killing memory B cells in the blood, but not in the tissue, it could be very tempting to use an anti-BAFF before rituximab to improve the response to rituximab. So the idea would be to get the memory B cells falling from the tissue to the blood, and then to kill the B cells with rituximab when they are in the blood. On the other hand, when you treat the patient with rituximab, you get an increase in the serum of the serum BAFF, just because there is no B cells in the blood, so no BAFF receptor. There is a mechanical increase, as you can see in these few patients, but also a true regulation by an increase in the mRNA of BAFF. And you can see these single patients, firstly, as an increase of the protein, and 11 weeks later, an increase in the mRNA. So it would be tempting to use an anti-BAFF after rituximab, just to avoid the stimulation of new autoreactive B cells via BAFF during the repopulation of the B cells after rituximab. And it is exactly what we have done in this protocol recently published in Sjögren. And we have tested this double combination here of rituximab in red and belimumab before and after rituximab. We have an arm with a double placebo and an arm with belimumab alone and rituximab alone. And what are the results? The main interesting results are these ones. We have looked at the B cells in the tissue. So we have made salivary gland biopsy before and after treatment. And you can see that the only group in which there is a decrease, even a disparition in some patients of B cells in the tissue, is a combination, Beli plus Ritux. And with Beli alone or rituximab alone, you don't have any B cell depletion. So that's very interesting to see that the combination may improve the tissue depletion of the B cells. Regarding the efficacy, it was not powered for that, but you can see that in green, the combination treatment was more efficient than either drug alone. And this was replicated in lupus. It was a randomized control study of adding belimumab or placebo after rituximab. And you can see the primary endpoint was the anti-DNA antibody. It was achieved, but it's not the most interesting for the patient. But if you look at the flare, there is a tendency to have a decreased flare with the combination. And if you look at the severe flare, it is statistically significantly less frequent with the combination compared with the placebo. So BAFF is these key cytokines, and for inhibiting BAFF, you can have another strategy. You can also design an antibody against BAFF receptor. And doing that, you are going to do the two actions. Firstly, you inhibit BAFF receptor, but secondly, you are going to deplete the B cells, exactly like rituximab, because BAFF receptor is only expressed on B cells. So you have the dual action of depletion of B cells and inhibition of BAFFs. And it is what does ianalumab, which is a new antibody which is in development in the clinics. So you can see this dual action. Firstly, you kill the B cells by just like the anti-CD20, by ADCC or CDC. And secondly, you inhibit after the linkage between BAFF and BAFF receptor. And interestingly, for killing the B cells, ianalumab is very, very potent. You can see that the dose of a drug which is necessary for killing the B cells, and you can see that ianalumab is in red is much more potent than rituximab in yellow, even than obinutuzumab. I will speak of it later here. Though the B cell depletion with ianalumab is very, very good. And you can see that in lupus, it's very promising. These results are not yet published. And you can see the difference of response between placebo and this drug in lupus. It is currently in phase 3 in the disease. We don't have the results of the phase 3, but it is clearly a promising drug. Another possibility of improving the B cell depletion is to modify the anti-CD20. And it is what does this antibody, which is obinutuzumab. It is a different CD20 epitope, and the drug is depleted in fucose, and then there is an increase of binding to the Fc region, and the ADCC is increased. And you can see that you can appreciate that the B cell depletion with obinutuzumab, the efficacy, the clinical efficacy, sorry, of obinutuzumab is interesting in this phase 2 in lupus nephritis, and it has just been confirmed in this paper in February in the New England in the phase 3, which is positive in lupus nephritis, and the drug just got its approval in the US by the FDA for lupus nephritis 1 week ago, as you can see. So we have discussed CD20, optimizing CD20 by inhibiting BAFF. Maybe it could be more interesting to inhibit CD19, because 19 is present later in the plasmablasts, which play a role in autoimmune disease and in early plasma cell. We had this data now 6 years ago to 19 in a neurological disease, which is optic neuromyelitis, or Devick's disease. It is a disease which induces some demyelination looking like multiple sclerosis, and associated with an autoantibody which is probably pathogenic, which is anti-aquaporin 4 antibody. As you can see, there is really a very good efficacy of inebilizumab, as you can see here. Again, you have a B cell depletion. It's not a surprise because it is an anti-CD19. And regarding the safety, it was very good, as you can see, not different than placebo. And if you focus on IgG, there is a slight decrease of IgG, but which is really not very dramatic and not very important. It is really very close to what we can observe with rituximab. And this drug was a little forgotten since 2019, and it reappeared very recently in two papers of this month in the New England. The first one in myasthenia gravis. Myasthenia gravis is associated with acetylcholine receptor antibody, and you can see the efficacy of ipilimumab globally in the disease, but especially in patients with acetylcholine receptor. And also in another disease, which is this interesting disease, a strong disease, IgG4 related disease. It is a disease with an infiltration of plasma cells, IgG4 plasma cell, and especially plasmablasts in different tissue. And you can see there is a dramatic effect on ipilimumab compared to placebo. Because this disease is really linked to plasmablasts, and plasmablasts do express CD19. There is a B-cell depletion, as you can see here, and also a very important decrease of serum IgG4, which are usually elevated in this disease. So let's move now to the possibility of targeting the plasma cell itself. And for that, we have different possibilities. CD38 expressed on plasma cell, but also on other cells, Pro-B, Pri-V, and immature B cells, but also on T cells, as you know. And also we'll discuss BCMA. So what about CD38? CD38, firstly, I just like to remind you that in Sjögren, we have a plasma cell signature in the tissue. We have shown that with the CyTOF now years ago. If you look at the glands, you have a different cellular signature, and especially plasma cells. If you compare the anti-Rho positive patients to anti-Rho negative or controls, you have plasma cells in the tissue. So we decided to use daratumumab, which is a drug which is anti-CD38, which is the drug is used in multiple myeloma, which is a cancer of plasma cell. And we decided to use the drug in two patients with Sjögren, with refractory Sjögren. The first one was a young lady, 17-year-old, and this young lady had a classical Sjögren with dryness, some articular pain, some episodes of fatigue, but she also had a huge hypertriglyceridemia, up to 50 grams per liter. And when you have that, you have a very high risk of pancreatitis. She was treated with Rituximab, as you see in purple, without any efficacy. And we treated the lady by 4 infusions, just 4. In myeloma, you treat for life of daratumumab, and you see the triglyceride decrease from 30 to 1. And she was treated, as you can see now, 2.5 years ago, and she's still in remission of this hypertriglyceridemia. Why? Because we decrease the level of the autoantibody against the lipase, and this lipase was responsible for the accumulation of triglyceride, and the autoantibody disappeared. And the second woman had a cryoglobulinemia associated vasculitis linked to Sjögren, and so it linked to glomerulonephritis, to arthritis, to purpura, as soon as it is cold. And she is linked to high level of rheumatoid factor, and she was treated by a number of drugs, Rituximab, cyclophosphamide, belimumab. And again, we used 2 years ago daratumumab, and you can see that she goes very well. She even spent her holidays in Laponie, which is a very cold country, as you know, and she kept very good, and rheumatoid factor dramatically decreased. So it could be an issue to use daratumumab in autoimmune disease. And it has been done in lupus. It is a small series of 6 patients with lupus nephritis. And you can just appreciate that the patient, it is the proteinuria completely disappeared, as you can see here. And anti-double-strand DNA antibody also decreased a lot after this treatment. But this treatment in this situation was continued for almost 1 year. Conversely to our 2 patients who were treated only during 1 month. So if we move now to the plasma cells and not to the B cells, in the plasma cells, the receptor which is very important for the survival of plasma cell is BCMA. And BCMA can be targeted by BAFF, but also by April. April cannot target BAFF receptor, that can target BCMA. So we can inhibit the plasma cell by inhibiting BCMA or by using, for inhibiting BAFF and APRIL, the soluble receptor, the Taki soluble receptor, which is fused to a Fc of IgG. If we do that, you can see it has been done in Sjögren by a Chinese team. It seems to work with this soluble receptor Taki. You can see here the decrease in the activity score of the disease. Here's a placebo. It doesn't move at all. It's a little, I'm astonished about that because in Western countries there is a placebo effect, maybe not in China. And it is a fatigue which is also improved. But what has been the revolution in the era of B-cell targeted therapy in autoimmune diseases, of course, 20 years after Rituximab, was the use of CAR T-cell in this disease, anti-CD19 CAR T-cells. And just to show you what is CAR T, but you do know what CAR T is, you transform actually a T-cell in a B-cell with the machinery of the T-cell. So you put at the surface of the T-cells an VH, VL, which are going to recognize a specific antigen on the target cells. Here it is an anti-CD19. The tumor antigen is the CD19, and you keep all the co-stimulatory domain, and this recognition of the target induces a cascade and a profound activation of the T cell with perforin and granzyme release, etc. So this German group in Erlangen treated 15 patients with refractory autoimmune disease with anti-CD19 CAR T cell, exactly the same CAR T which is used for treating lymphoma. You can see that 8 of these patients had lupus, 3 had inflammatory myositis, and 4 had scleroderma, systemic sclerosis. And you can see that all the patients with lupus got remission. Remission, you can appreciate remission by the SLEDAI, which is an index of activity. And very interestingly, anti-double-strand DNA antibodies, which are really the antibody of the lupus, completely disappeared in all the patients. It's very striking. Patients with nephritis got remission. There was this relapse, and he got remission later. The C3 improved. And if you look at the myositis patients, it is really close to what was found in lupus. It is a muscular enzyme, the CK, and here's a long term of patients with scleroderma. So if we look at the different autoantibodies, as I said, anti-double-strand DNA disappeared, but other type of antibody could not completely disappear, like anti-Ro60, for example, which can be present in lupus, but also in Sjögren. They decreased, but they did not disappear, as you can see here. The very important slide is this one. What happened regarding the B cells? The B cells disappeared for 3 months, and after 3 months, the B cells reappeared in the blood. So they reappeared earlier than with Rituximab. And what you can see in this reappearance is that what reappeared is only naive B cells. The memory B cells, which were very increased before CAR T cells, went to 0, and after repopulation, there was very few memory B cells. Whatever they are, a pre-switch, switch, it is the same. Plasma blasts were very low after CAR T cells, as you can see here. And finally, what we observed is a reset of the B cell repertoire. No relapse despite this B cell repopulation, probably because there was more naive B cells, less memory B cells, less plasma blasts, and which can be associated with persistent drug-free remission. Of course, there is a price to pay, like with every drug. And what is really common with this type of treatment with CAR T cells is a cytokine release syndrome. It is very well known in lymphoma, and it occurred in these patients, 11, about 15, but it was very rarely severe. It is just fever, and you can really treat that with anti-IL-6 receptor antibody with tocilizumab. A more complicated side effect is ICANN. It is a neurological complication. We don't understand why there is sometimes this neurological complication. It can be very severe in lymphoma. In these patients, there is only one patient with dizziness, and it results with dexamethasone very rapidly. You can see that the immunoglobulin had a slight decrease, but very moderate, not complete disappearance, because we target B cells and not plasma cells, just remind that. And it was also, there was a new series, but I will go maybe a little faster, in systemic sclerosis from the same group, 6 patients, and you can see again a very nice improvement of activity. Systemic sclerosis is a disease very difficult to treat, so it can be also interesting. Again, you have this decrease in anti-nuclear antibodies, not complete disappearance, anti-topoisomerase 1, which is anti-ribonucleoprotein antibody. It's not DNA. And you can see in this patient, there is a relapse of antipolymerase 3, as you can see, after 1.5 years. So there is also the possibility to design some CAR T cell recognizing not only CD19, but CD19 and BCMA. The idea is to deplete completely both the B cells and also the plasma cells. It has been done by this Chinese team, you see in lupus, and again with a very spectacular result, 13 patients with 12 about them responded. You can see the same type of graphs. You can see the B cells, which reappear very early. You can see 2 months here. You can see also the CAR. The CAR are present during the first months, and the CAR disappeared after 1 month. It is the reason why the B cells reappear after 2 months. And again, a very nice decrease of different autoantibodies in these scleroderma patients. We spoke of CRS, we spoke of ICANN. There is another theoretical risk, which is the possibility of inducing a T-cell lymphoma if the chimeric receptor was introduced in an important part of the genome of the T-cell. And in lymphoma, in B-cell lymphoma treated by CAR T-cell, there is roughly 20 cases of T-cell malignancy. But it can not be mandatorily linked to the CAR T. In 3 of the 20 cases, the CAR was present in the lymphoma. But there is this recent paper showing that the CAR T for treating lymphoma patients was integrated in P53. And these patients developed a very aggressive T-cell lymphoma linked to the disruption of P53, which is a very important anti-oncogene. So CAR T-cell work, is there an alternative to induce this profound B-cell depletion? And CAR T-cell work because they may induce the tissue B-cell depletion. If it is the mechanism of action of CAR T, maybe we could do the same job by an easier way. And it is what is called T-cell engager bispecific antibodies. So the idea is to use a bispecific. It is what is called a BiTE because it is only the VH NVL and not the FC, with combining anti-CD3 and anti-CD19, as you can see. And this drug is known blinatumomab. And it is used, for 20 years for the treatment of refractory acute lymphoid leukemia in the US and in Europe. And this drug, blinatumomab, has been tried in rheumatoid arthritis, in refractory rheumatoid arthritis. It's complicated to use because it's IV, continuous IV, as you can see, for 7 days, 5 days, and after there is a pause, and after again 5 days. But what you can see is that you have a very good response. You can see here it is index of response. And when you look at the joint, you can see that the B cells, CD20, completely disappeared, almost completely disappeared. CD19, we can't see anything. And even CD138, which is a plasma cell marker, there was quasi-complete disparition of these cells in the joint after the drug. There was also a decrease in the autoantibodies with this T-cell engager bispecific. Some adverse event, globally it was well tolerated. The modest decrease in immunoglobulins, and exactly like with CAR-T, you can see that after the drug, you have this expansion of naive B cells and this exhaustion, this disappearance of memory B cell, non-switch or switch memory B cells, as you can see here. So for finishing, a target interesting is BCMA. As I've shown you, it is present on plasma cell, it is present on plasmablast, and also in a large part of B cells, memory B cells, and a part of the germinal center B cells. So BCMA could be an interesting target, but for some reason, I don't know exactly why, if you target BCMA only, you have probably an internalization of the receptor, and it doesn't work in multiple myeloma. So the idea was to design a bispecific recognizing CD3, again, T cells, and BCMA, and to activate the T cells, and the T cells are going to kill the tumoral plasma cell in multiple myeloma. And these drugs now are used in multiple myeloma, very commonly used, and they are very efficient. And these drugs were tested in some inflammatory disease. A very small series, again, in Germany, in the same center, 4 different diseases: systemic sclerosis, Sjögren, myositis, and rheumatoid arthritis, and only 2 doses of teclistamab. You can see in multiple myeloma, it is continued over time, 2 doses, and a good tolerance, and a very interesting efficacy by different scores in the different diseases, as you can see here. What if you can appreciate here that there is a decrease in autoantibodies, but not a disappearance. Maybe it is because these antibodies are not desoxyribonucleotide antibody, but again, ribonucleoprotein antibody. Of course, if you target plasma cells, you may get a total decrease of plasma cells, and there is a decrease in IgG, but it remains reasonable because there is only 2 infusions, and some of these patients required IgIV, but most of them no. And that was the same, exactly, example of efficacy of this drug in lupus. And you see it is exactly what you have seen with CAR T cell, the decrease in proteinuria, the improvement of hemoglobin, and mainly the disappearance of anti-DNA antibody. And as you can see here, the repopulation of the B cell just with naive B cells, and the memory B cell and plasmablasts in pink and blue had completely disappeared at the reset. So what are we doing now in our unit and in our hospital with this possible revolution of these new B cell depleters? Firstly, we would like to set up a cohort of patients with refractory autoimmune diseases with bispecific antibodies, because these drugs are very easy to use. As you know, we treat in the department patients with multiple myeloma, and we have treated at least 15 patients with these drugs, teclistamab or elranatamab, and the safety is very, very correct and very. So it can be done in any medicine department. But today the companies are very reluctant to give the drug for other indications that malignant hematologic disease, but we continue to try. The second option is to begin CAR T-cell. For that, we need to convince pharma to set up some trials, because until now, we can use in hematology only CAR T-cell from the companies, mainly from Novartis and BMS. We begin to, the objective is to be able to produce academic CAR T-cells in the country, but it is not yet operational. So we are going to begin a trial with the Novartis CAR T in refractory area in Sjögren. And with the Gustave Roussy Institute, we really are progressing on the possibility of producing academic CAR T cells. We got the approval of NSM, and we are very optimistic for beginning a trial with academic CAR T, and will be the first one in France at the end of the year with Gustave Roussy. And last, for finishing, maybe it's good to deplete all the B cells everywhere, in the blood, in the tissue, but maybe it will be smarter to deplete only the autoimmune B cells. And it is a project we have with Samuel and John. And so we are developing a model, a mouse model of Sjögren, by immunization with an antigen, which is Rho60. It is the same antigen in mouse and in humans, so it's interesting. So we immunize the mice with the peptide, and after we are going to treat the mice with different options. The full option, the full depletion, CAR-T anti-19 or Bispecific, the classical B-cell depletion, and the depletion of only autoimmune B-cell. How do you do that? We are going to design a bispecific with one arm anti-CD3, and the other arm, we are going to put the antigen and not an antibody. So the Rho60. So the Rho60 antigen is going to bind only the B cells expressing anti-Rho60 antibody. And we can do the same with a CAR-T because it's called a CAR. So rather than putting the anti-CD19 at the surface, we are going to put the antigen at the surface. So it is absolutely fascinating, and I hope we could be able to show you some results maybe in 1 or 2 years with Samuel, and it is in collaboration with Camille Bigenwald and Gustav Roussy. We have created this club, Innovative Immunotherapies in IMID, regrouping patients over the country, not patients, but doctors and researchers among the country interested with these new therapies. And what we'd like to do is to do, the objective of this club was to design a basket trial with some B-cell driven autoimmune disease, because now we have to do randomized trial, really to demonstrate this drug could be efficient in the patient. So we could use a bispecific or a CAR-T cell, and we have to compare, and I've shown you that we have very good classical option of B-cell depletion. So we have to compare to a classical option of B-cell depletion, like one of these 3 drugs. So again, it will be also an objective of the FHU care that has been reconducted with Samuel and Camille at the top of this FHU. So to conclude, CAR-T cell targeting CD19 are efficient in lupus and other autoimmune disease, but large-scale dissemination will be difficult, even if they will become simpler. I didn't tell you the price of a CAR-T cell treatment. It is around 300,000 euros today, at least. The mechanism of action is probably just a profound B-cell depletion, and thereafter a reset of the immune system to naive B cells. And this profound B-cell depletion, we have to remind that it can be achieved by other simpler methods, new anti-CD20, combination 20 BAFF receptor, bispecific antibody. The depletion of plasma cells has to be considered, mainly in lupus and Sjögren, and we need to have now randomized trial for really demonstrating the interest of this new strategy. And I'd like to thank all the team on the left, and especially, as I've said, Samuel and Jan, we are developing this new project in the team. Thank you very much for your attention.